have a talk titled Diagnostic Approach to Granulomatous Lesions in Lung. And our presenter for the day is Dr. Sanjay Mukhopadhyay, who's a director of pulmonary pathology in Cleveland Clinic at Cleveland, USA. Chairpersons for the day are Dr. Mahima Bhaskar, who's a professor in Department of Pulmonary Medicine at Tata Memorial Hospital, Mumbai, and she's also a consultant pulmonologist at Hiranandani Hospital. And we have Dr. Alpa Dalal, Head of Department Pulmonology, Jupiter Hospital, and she's also Head of Unit at GTB Hospital, Mumbai. I would like to welcome our speaker and the chairpersons. So moderators for the day is myself, Dr. Preeti Mansukhani. I'm a pathologist at Rashid Hospital, Dubai. Along with me, I have Dr. Komal Deshmukh, who's a consultant pathologist at Star Super Speciality Hospital, Nagpur. Webinar hosts are Dr. Anita Borges and Dr. Sumit Gujral. Few reminders. Very important, please note, do not send any annotation request to the presenter as it really disturbs the presenter during their presentations. Few of the disclaimers. Some more disclaimers. So I would like to also tell you about the upcoming talks. Our next slide seminar is on lung and mediastinal lesions by Dr. Rajiv and Dr. Subhash from Tata Memorial Hospital. That's on 13th of April, followed by another talk on 18th of April, an approach to interstitial lung disease by Dr. Henry Talazar. So with this, I would like to welcome our speaker, Dr. Sanjay, and I would like him to start. Over to you, sir.
Thank you so much, Dr. Preeti and Dr. Komal, and also to Dr. Sumit Gujral for inviting me. Thank you so much for making this possible. I'm going to share my screen and just let me know if it's working.
Yes, sir.
And then we'll get going. So when you can see my screen, just let me know.
Yeah.
Perfect. And when I launch my slide, just tell me if you can see the full screen.
Sure.
Yeah? Okay. Yeah. All right. Thank you so much. So we're going to do a whirlwind tour of granulomatous lung disease. And I'm going to share with you how I approach these lesions. So I'm basically trying to show you what I do when I look at one of these cases in my practice. So granulomas of the lung. I think all of you know that among the benign causes of lung masses, some of the most common, I think by far the most common benign cause of lung masses are granulomas. And among those, the most common are mycobacterial and fungal infections. And then there are relatively less common non-infectious causes of lung granulomas. There's a lot of literature on this. I've cited some of the review articles that you might find helpful in the archives of pathology and lab medicine. You should know what a granuloma is, and I think most people do, but it's worth re-stressing. It's basically a compact collection of epithelioid histiocytes. I remember that when I did this talk in 2021, Dr. Borges said that maybe this is too strict a definition, and I acknowledge that. This is the definition I use. Compact collection of epithelioid histiocytes. It may or may not be surrounded by lymphocytes, which are the purple dots there. Sometimes you get a multinucleated giant cell or two or many, and that's also an option. But really the key is the epithelioid histiocytes, that they should be compacted together. And of course, you will get sometimes necrosis, which is the yellow area there. So all the other things, the lymphocytes, the giant cells, the necrosis, those are all variable. What's always present is a collection of epithelioid histiocytes. And for me, the most important feature, by far the most important feature, is necrosis. And that's how I start my approach to these lesions. When I see necrosis, I'm thinking by far mycobacterial or fungal infection. And then I have a few more things down that differential line. Usually granulomatosis with polyangiitis or Wegener's is next. Maybe rheumatoid nodule is next down that list. So infection, granulomatosis with polyangiitis, rheumatoid nodule would be my top three for necrotizing granulomas. And when you go down the non-necrotizing granuloma route, sarcoidosis is by far the top of my list. Sarcoidosis, of course, infection, aspiration, berylliosis, many other things come down that route. So necrosis is really the beginning of the algorithm. So let's start with a question to the audience, and maybe the moderators can tell me how the responses are going. So yes, in terms of the question, it is the type of necrotizing granulomas seen in the lung are I don't know what the question says, most common in, are also seen in blastomycosis? Or is the answer parasitic and viral infections? Or histoplasmosis and non-tubercular mycobacterial infection? Or none of the above? Caseating granulomas are pathognomonic of TB. Maybe I'll give you a few seconds to answer, and the moderators can tell me when I should reveal the correct answer.
So, sir, the majority of our attendees says is option 3,
Okay.
histoplasmosis and non-tubercular mycobacterial infection, followed by a second majority for none of the above, caseating granulomas are pathognomonic TB.
Okay, that's perfect. Actually, and that's the reason I put this question in, is to see whether anybody thinks that caseating granulomas are pathognomonic of TB. And I think the rest of the talk, basically, I'll be showing you that they are not pathognomonic of TB. First of all, I hate the term caseating. I don't want to hurt anybody's feelings, but caseating is really not a microscopic term. It's a term for a gross appearance, cheese-like gross appearance. It should not be used for a microscopic appearance. And that kind of necrosis, that kind of pink, disintegrating sort of necrosis that you see in TB is not specific for TB. You can see that in histoplasmosis, in non-tubercular mycobacterial infection, coccidioidomycosis, and other infections. The only reason you might think it's pathognomonic of TB is because you've only seen it in TB and you have not seen the other infections. Once you see the others, that concept melts away. So the correct answer here is histoplasmosis and non-tubercular mycobacterial infection. So that kind of pink necrosis that you see in TB is not specific for TB. Let's start. I'm going to break the talk into 3 parts: necrotizing granulomas with organisms, necrotizing granulomas without organisms, and non-necrotizing granulomas. So let's start with the first one. There are some common themes that apply to all mycobacterial and fungal infections. And I'll use histoplasmosis as an example to illustrate these themes, to show you how the different forms of the disease occur. And this applies to TB, to non-tubercular mycobacteria, and to the 4 common fungal infections in the West, at least: histoplasmosis, cryptococcosis, blastomycosis, and coccidioidomycosis. So I'm going to use histo as the sort of way to describe these infections. So in histoplasmosis, you get what's known as acute histoplasmosis, which is when you first inhale the organism, and that's typically in an immunocompetent patient. And what you get is a sort of lymphohistiocytic infiltrate that is the body's first response to inhalation of the organisms. The same thing, or roughly similar things, also happen in other mycobacterial and fungal infections. But in immunocompromised patients, so people with HIV/AIDS, transplant recipients, other kinds of immunocompromise, the same person might inhale the organisms but will not be able to mount an immune response to that. And in these patients, the infection, instead of remaining localized to the lung and being destroyed by the lymphohistiocytic infiltrate, actually gets inside the macrophages and disseminates. It disseminates via the lymphatics, the bloodstream, hematogenously, all over the body. So it goes to the liver, the spleen, the blood, the lymph nodes, virtually everywhere, the adrenals. And this same theme can be applied to coccidioidomycosis, to cryptococcosis, to tuberculosis. And you get, when the same disseminated infection comes back into the lungs and forms multiple small nodules, that's called miliary. So miliary histoplasmosis, miliary tuberculosis, miliary coccidioidomycosis. So miliary spread is a consequence of widespread dissemination in all of these infections, and is usually the worst form of the disease. And then the third form of the disease that happens in all of these infections is the healed form of the disease, where the infection has been localized to one focus. Many of the bugs have been killed off, so you get an area of necrosis in the middle, and it's surrounded by a granulomatous rim. In histoplasmosis, the killing is so efficient that most of the bugs are completely destroyed, and the organisms are rendered non-viable. They don't grow in cultures. In other infections like TB and cryptococcosis, the organisms might still be viable and grow in cultures, even from these old lesions. So they're called histoplasmoma for histo, they're called tuberculoma for tuberculosis. But the idea is the same. It's a walled off, contained infection within a necrotizing granuloma in the lung. So we've talked about this. Acute infection occurs in all of these mycobacterial fungal infections, starts with inhalation of the organisms. We reported this in acute pulmonary histoplasmosis in 2010 with 4 of these patients who presented with acute symptoms, 3 to 14 days in duration. And one of these patients was a 45-year-old male construction worker who presented with fever, headache, nausea, vomiting, and dyspnea for 7 days of duration. On the first day, he was exposed to moldy environment inside a home with dead bats, and that's where he was exposed to histoplasma spores. And then the symptoms started on day 2, presented to the physician on day 7, and presented to the emergency room on day 9. This was the chest X-ray, shows bilateral diffuse sort of a miliary haziness, and the chest CT shows bilateral, tiny nodules and reticulonodular opacitals. And you can see that's very nicely recapitulated on the lung biopsy, where you see these multiple nodules. The histology of this showed a sort of diffuse lymphohistiocytic infiltrate with areas of necrosis, as you can see on the bottom, and an occasional multinucleated giant cell. But no well-formed granulomas were present. Vascular inflammation was present, and this is also a common theme in mycobacterial and fungal infections, that you can have vascular inflammation that is very common in these and should not be misinterpreted as a true vasculitis. A Crocott methenamine silver or GMS stain was positive in these cases and showed histoplasma east with narrow base budding. So the diagnosis in that case was acute pulmonary histoplasmosis. The patient was one of 5 construction workers, all of whom came down with a similar illness. Lung cultures were also positive for histoplasma in our patient, but later, because histoplasma is a slow grower, he was treated with itraconazole and recovered. 2 other of his co-workers became positive for histoplasma, seropositive. What happened later? Well, after treatment, his imaging findings completely resolved over time, and 2 weeks later, his infiltrates had completely gone away. And this is the common thing with many of these diseases. For example, valley fever or coccidioidomycosis, you get an acute illness, often it doesn't even come to treatment. It mimics a flu-like illness. The patient recovers after a few days to weeks. So this is also a common theme. In immunocompetent patients, they clear their infection spontaneously and usually don't require therapy. Only severe infections of the kind I showed here require therapy, and even those usually resolve. Then once the infection resolves, you get this healed sort of residuum of prior disease, which is called an OMA, because it mimics cancer, a histoplasmoma, tuberculoma. It's usually an incidental finding found on CT scans performed for other reasons. You broke your shoulder, you're having, follow-up for breast cancer, and you incidentally note a small lung nodule, and you biopsy that or dissect that. In histoplasmomas, cultures are always negative because the organisms are dead. And in fact, the Infectious Disease Society of America recommends that no treatment is required in solitary histoplasmomas in immunocompetent patients. This is what they look like. They are the classic necrotizing granuloma that you see in tuberculosis, but they are also seen in histoplasmosis. If you do a GMS stain, you will see the oval or tapered shaped organisms, but it is otherwise identical to tuberculosis, a fact that was noted many, many years ago by pathologists in the US. These lesions can also be biopsied, and you will get the classic necrotizing granuloma that you get in TB and other infections. The only way to tell them apart is that on GMS, you see the organisms. One interesting thing about histoplasmomas is that you do not see the organism on H&E within the necrosis or within the histiocytes. So this is very different from disseminated histoplasmosis, where you do see the organisms on H&E. So you don't see it on H&E. You absolutely need a GMS stain to see them. Like I said, histoplasma is non-viable in histoplasmomas, and there are many studies that show this. Sometimes these things are resected because the biopsy was non-diagnostic or for other reasons, and they show the classic features of a lung nodule with central necrosis and a granulomatous rim with variable numbers of Langerhans type or foreign body type giant cells. Again, a GMS stain is diagnostic. You see these oval to tapered yeasts that are uniform in size and occasionally show narrow based budding, like seen here. All right. And then we have our third form of the disease, which is disseminated disease. And in this, the presentation can be primarily pulmonary with miliary disease. Extrapulmonary disease might not always be evident at presentation, and clinicians may not have considered that the diagnosis is histoplasmosis, let alone that is disseminated histoplasmosis. This is the classic form of the disease that you'll get asked about in board examinations, in your other exams, that were described by Darling way back in 1905 in the Panama Canal, where the macrophages are enlarged, they are parasitized by these numerous histoplasma yeasts, and similar things happen in TB and in non-tuberculous mycobacterial infections, also in cryptococcosis. And this is the form that is the most dangerous for the patient, that can be fatal without treatment, that causes lots of problems unless it is promptly treated. So histology is very important here, because histology gives you an answer in 1 or 2 days, whereas cultures take weeks to grow, sometimes 2, 3, 4 weeks. So very important to pick up the organisms in this form of disease. Traditional diagnosis requires a history of immunosuppression, evidence of disseminated disease, multi-organ involvement, and then cultures or biopsies show histoplasma, and you make the diagnosis like that. You can also use the urine antigen or serology for histoplasma, which is not completely sensitive or specific. We published our experience with disseminated histoplasmosis diagnosed in the lung a few years ago. And these are some of the pictures from those cases. Diffuse bilateral infiltrates, ground glass to reticulonodular, and transbronchial biopsies were diagnostic in some cases with GMS positive organisms. Cultures were also positive for histoplasma, but 2 weeks later, so after the biopsy. In some cases, we saw diffuse alveolar damage, and that can happen with disseminated histoplasmosis. You can see on the right-hand side how clear it is to see these organisms. It's very similar to disseminated leishmaniasis, except that the leishmaniasis doesn't occur in Ohio or in New York State, where these biopsies were taken from, and certainly not in the lung. But again, this was a core needle biopsy, and you can see right on the H&E, you can see these very characteristic histiocytes full of organisms. The pathologic diagnosis was disseminated histoplasmosis in this case, and the clinician said, well, it can't be disseminated because there's no evidence of dissemination. But we assured them this morphology actually predicts dissemination, and indeed, the lung biopsy cultures were positive 10 days later, but the bone marrow biopsy cultures were positive 31 days later, so was proven to be disseminated based on a lung biopsy morphology. Let's move to question number 2. Question number 2 is, you find fungal yeast in the lung granuloma. You can see them on H&E. They're small. They have a light gray cell wall. They show narrow base budding, are pleomorphic, that means they have size variation, and are surrounded by halos. Let me add also that they are positive for muscicarbon. Which of the following organisms is most likely? Histoplasma, Cryptococcus, Blastomyces, or Coccidioides? Over to the moderators to tell me when to reveal the answer.
Yes, sir.
Thank you so much.
The attendees are answering.
That's great. How are we doing on time? It's about 13 to 15 minutes in, so I think we're doing okay for time.
Yes, sir.
Do we have any guesses from the attendees?
So far, unanimously, everyone has gone for option 2.
Cryptococcus.
We have no other answer apart from that.
Very good, very good. And they've got it right. So the 2 things that here make it Cryptococcus is pleomorphism. That happens in Cryptococcus, but not histoplasma. And then muscicarbon, I said, was positive. That happens in Cryptococcus, but not histoplasma. The other ones don't really fit the description. Blasto and Cocci are larger, don't show narrow base budding. So yes, you guys are very good. Well done. The answer here is Cryptococcus. So Cryptococcus looks like this. This is a cryptococoma or a solitary lung nodule with Cryptococcus organisms. And you can see they are small yeast, very similar to histoplasma in some ways, but they are musicarmin positive. You can see the musicarmin on the below right-hand side. I've shown you examples of a PAP stain for those of you that do cytology, and also a diff quick for, again, those of you who do cytology, to show you what it looks like on those stains. And you can see the narrow base budding in the left-hand side circle. And on the right-hand side circles, you can see the size variation. So very small yeast and very big yeast. The one is musicarmin positive. So you can see that that size variation is very helpful in making this diagnosis. Let me show you some histology and radiology. So in this case, there were bilateral lung masses. You can see musicarmin positivity, but on the H&E, these organisms are faintly stained, but clearly seen. So you can see them usually within a space or surrounded by a halo. People often say that the halo is caused by the capsule, but I don't believe that, because when you stain the organism with musicarmin, the cell wall stains, and probably the capsule too, but the space, the halo, does not stain with musicarmin. So if it were the capsule that were causing musicarmin positivity, then the whole halo would be positive for musicarmin, and that does not happen. So I'm very skeptical of the idea that the halo is actually caused by the capsule. I think it's more likely to be a retraction artifact. You can see on the GMS stain that there's a lot of pleomorphism, and the fungal sizes vary considerably. Here's a cell that's called a crouton cell, somewhat humorously named crouton cell, which is a combination of Cryptococcus and Teuton-like giant cell. It has a foamy-looking cytoplasm at the edges, but the difference from a Teuton cell is that the foamy part contains Cryptococcus yeasts. Now let's move to blastomycosis. That's another one of the endemic fungi here in the United States, seen in the Great Lakes area. Like Chicago, for example, sees a lot of Wisconsin, the state of Wisconsin sees a lot of blastomycosis. It frequently causes these large consolidation-like lesions. You can see air bronchograms in this consolidated lesion on the right-hand side. Causes large masses and consolidation-like lesions that can progress very rapidly to ARDS and death. Is seen in people who work with wood in outdoors, rural areas. And the characteristic of blastomycosis is broad-based budding. So it's very easy to remember. Blastomycosis, broad-based budding, B, 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 B. And what broad-based budding means that the daughter yeast is connected to the mother yeast by a broad base. And you can see that both on the H&E and by GMS. Another helpful finding is that within the yeast, you see nuclear material. It's purple. It's probably chromatin material that's within the yeast.
Sorry,
It's
sir,
very
if I may
helpful.
just interrupt here. If you can use the
Absolutely.
laser pointer,
Yes,
then it would be.
like this.
Yeah, so
There.
right click and you'll find the pointer options, and you can use the laser pointer.
Oh, I see. So I can do that. You
Yeah,
guys see it
pointer
here?
options. Yes, sir.
So this
Yes.
is the yeast with broad-based budding. This is the area of consolidation. This is the nuclear material. And then you can see the broad-based budding here, and this is a GMS stain over here. In this particular picture, which is really a beautiful picture that captures everything you see in histoplasma, in blastomycosis, sorry, you see the characteristic features. You see the broad-based budding, the nuclear material. You see a giant cell, so granulomatous reaction is part of the picture, and you see neutrophils. So neutrophils are a very characteristic part of the tissue reaction to blastomycosis. In fact, in the old days, these lesions used to be called pyogranulomatous, meaning a combination of pus and granulomas, pyogranulomatous. So those types of suppurative granulomas are very, very suspicious for blastomycosis when you see them. Here's another picture showing you a large mass in the lung with this sort of cavitary lesion. And you can see here a granulomatous reaction with a blastomycosis yeast. And you can see the characteristic broad-based budding here with the nuclear material. Very, very classic for blastomycosis. In fact, it's so classic you don't have to wait for cultures. You can call it blastomyces. It's absolutely pathognomonic. Now let's move to coccidioides. So coccidioides is endemic in the southwest of the United States. So Southern California, New Mexico, Utah, Western Texas, and also the northern part of Mexico is endemic for coccidioides. Lots of people get it there, same as tuberculosis in India or histoplasmosis in Ohio. Lots of people get coccidioides just by living in Arizona and Southern California. And those coccidioides lesions also sometimes form masses, lung masses. You can see the lesion being biopsied with a CT-guided core needle biopsy with a lot of necrosis on the core. And within that, you see a typical coccidioides spherule. The spherule is filled with smaller yeast-like forms, which are called endospores. And here, in a case of disseminated coccidioidomycosis, you see both empty spherules and a spherules filled with endospores. Again, this lesion in a person from an endemic area in a lung lesion is virtually diagnostic or pathognomonic of coccidioides. So just to recap all our fungal organisms, here's a GMS on a histoplasma case, small yeast, very uniform, narrow base budding. Here's Cryptococcus, also small yeast, but with a lot of pleomorphism, narrow base budding, lot of size variation. Here is blastomycosis, and you can see the characteristic broad-based budding, and organisms are much larger. And here's coccidioides with the typical endospore-filled spherules and also empty spherules next to them. So I hope you can see the difference between these four organisms. I'd now like to shift gears and show you an example of the fact that necrotizing granulomas can be very close mimics, very close, of lung cancer. I'd like to show you this example. This is a spiculated nodule, lung nodule in a patient with emphysema, very heavy smoker, elderly patient. There's tethering of the lesion to the pleura. And clinically, this was thought to be very suspicious for lung cancer. The patient had a history of bladder cancer, a prior lobectomy for lung adenocarcinoma, and also liver adenocarcinoma, and had a growing right upper lobe nodule that was detected on follow-up CTs for the prior lung cancer. It grew from 3 millimeters to 1.8 centimeters over a period of 18 months and was PET positive with an SUV of 3.3. So plugging it into our risk of lung cancer calculator, this gets a very high score because of the age of the patient, the pack years of smoking, former smoker, emphysema, PET avidity, upper lobe lesion. So by all clinical measures and radiologic measures, this is highly suspicious for lung cancer. But is it lung cancer? Well, the thoracic surgeon said it's concerning for malignancy. The radiologist said it's concerning for primary lung cancer. And a expert thoracic radiologist here at Cape Clinic said it's for sure malignant. Well, it is not malignant. This is a necrotizing granuloma. You can see the central necrosis on the left-hand side picture right here. And on the right-hand side, you can see that this is full of fungal hyphae with a morphology that is quite suspicious for aspergillus. So narrow angle branching, dichotomous branching, septate hyphae. And this did indeed prove to be aspergillus by cultures or PCR, I forget which one. This and similar cases led us to publish our experience with cases of aspergillosis that were neither cavitary nor aspergillomas nor invasive pulmonary aspergillosis, but a special form of aspergillus that forms solid lung nodules. Solid lung nodules in the upper lobes of smokers with emphysema is a very distinctive syndrome that is called the solid variant of chronic necrotizing aspergillosis. Is a very, very good mimic of lung cancer clinically. And it forms these large necrotizing granulomas within which you can find fungal hyphae. The pathologic diagnosis is actually quite easy. And then you can prove that this is aspergillus either by cultures or by PCR. But what is most striking about these patients is the very consistent occurrence in COPD patients in the upper lobes and in heavy smokers. Another very rare cause of necrotizing granulomas in the lung is candida. In fact, most of the time when you get candida in the lung, it's a contaminant. It is not a true cause of disease, but candida pneumonia does occur in immunocompromised patients, for example. And we have seen a case and published that where we had suppurative granulomas similar to blastomycosis. But within that, we had candida. The clinicians did not buy our diagnosis. We had to send it off for PCR, which grew candida. They didn't agree with that. Cultures also grew candida. They didn't agree with that. We sent it again for PCR to a different lab, and that also grew candida. So 3 different ways of proving that this was candida. And then after antifungal therapy, these lesions cleared up completely. So there was a successful treatment of granulomatous infection due to candidiasis. Very, very rare case. And then we'll move on to mycobacterial infection. So I'm not going to talk about this much because you guys you see this day in and day out. What I will just refer you to is this nice paper by our group. The first author was Dipali Jain from AIMS, where we collated our experience on all the tips and tricks we have learned over the years for finding AFB in necrotizing granulomas. So I would recommend, if you don't if you haven't read this paper, please read this paper. You will find it very, very helpful in your daily practice because you see so much mycobacterial infection. So I'm not going to talk much about TB because you guys know about that already. What I'm going to talk about is what can mimic TB. So here is an example of a 68-year-old woman with hemoptysis, a large cavitary mass, and a positive P ANCA. Now, with the positive P ANCA, this case was thought to be suspicious for a vasculitis, especially granulomatosis with polyangiitis, or formerly known as Wegener's. And indeed, there was some vascular inflammation, as you can see here. There was also very striking granulomatous inflammation in blood vessels. There was dirty necrosis. There was geographic necrosis, as is often mentioned in Wegener's. So why is this not Wegener's? It looks very much like Wegener's. Well, why it's not Wegener's is because the AFB stain is positive, and you can see here lots of AFB positivity here. Does that mean it's tuberculosis? In fact, it does not, because cultures and PCR both confirmed here that this was not tubercular infection. This was non-tubercular mycobacteria with Mycobacterium avium complex. So I would say, especially for an audience that is predominantly in India, that the biggest concept you must get rid of from your head is that if you have a necrotizing granuloma with AFB, that necessarily means tuberculosis. Maybe it mostly means tuberculosis, but not necessarily. Then you will find some cases that will prove to be non-tubercular mycobacteria, especially Mycobacterium avium complex, if you do cultures and PCR. And that's really my take-home message for you, other than the fact that P ANCA does not prove a vasculitis, and vascular inflammation does not also prove a vasculitis. So always be on the lookout for mycobacterial and fungal infection when you see a necrotizing granuloma. Non-tubercular mycobacterial infections frequently cause granulomas and giant cells in the airways, in the bronchi and bronchioles. They can look very much like TB or like sarcoidosis. They can mimic that histologically. So really, cultures are very, very important here. They can cause lung nodules and granulomatous inflammation that is absolutely identical to TB. There's no way to tell these apart. And that, I think, ends our section on lung granulomas with organisms. So we're going to move on now to lung granulomas without organisms. I'm going to show you quickly some of the main things that you will run into. So what is the menu to think about when you get a necrotizing granuloma, but your bug stains are negative? So first of all, you can get infections where the organisms have been destroyed, and it's still an infectious etiology. But what else to think of? So let's move to question 3, surgical lung biopsy from a 54-year-old male with bilateral cavitary lung masses shows necrotizing granulomas with dirty necrosis. Which of the following is the most robust evidence that this is granulomatosis with polyangiitis or Wegener's? Is it a positive P ANCA? Is it granulomas in blood vessels? Is it microabscesses? Or is it a positive C ANCA? Over to you, moderators.
Yes, sir.
I think this should be a fairly straightforward question. I see people are answering 2 and 3, 2 and 3, 2 and 3, 2.
Yes, sir.
Interesting. All right, so let me address that. So you've already seen that P ANCA is not necessarily specific for Wegener's. The second thing to remember is that granulomas in blood vessels are not specific for Wegener's. They can also occur, they actually occur more commonly in sarcoidosis than in Wegener's, and they are not specific for GPA. Microabscesses are also not robust evidence of GPA. They occur in infections of all kinds, including blastomycosis that I showed you before, and other infections, and in aspiration pneumonia. So microabscesses are not specific for Wegener's. What is really helpful in this setting is a positive C ANCA. So C ANCA, although not 100% specific, is very, very specific. So in the histologic context of what looks like GPA, if you also get a positive C ANCA, that's very, very helpful information. So the correct answer is a positive C ANCA is the most helpful in this setting. So what does GPA look like? One of the common things is dirty necrosis. So necrosis with a basophilic hue with a lot of karyorectic debris. This is what the necrosis looks like there. Blue or purple instead of the pink stuff that you see often in infections. But infections can also look like this. Remember, C ANCA more specific than P ANCA. Another feature of granulomatosis with polyangiitis, which is virtually pathognomonic, not common, very difficult to find, but pathognomonic, is necrotizing vasculitis. And this is vasculitis that destroys a portion of the vessel wall while leaving the others intact. So you can see on the right-hand side, most of the elastic layer is intact, but this part of the vessel is destroyed. This sort of eccentric vasculitis, which is caused by neutrophils and histiocytes, destroying a portion of the vessel wall, very, very characteristic of GPA. And if you can find it, by recuts, by doing stains, it's very helpful to make the diagnosis. Other than this finding, necrotizing vasculitis, no other finding is pathognomonic of GPA, or no, even other combinations of findings, although suspicious, are not pathognomonic of GPA. A similar entity to GPA, but very, very eosinophil rich and occurs mostly in asthmatics, is eGPA, or eosinophilic granulomatosis with polyangiitis. Looks a lot like GPA with necrotizing granulomas and necrotizing vasculitis, but has innumerable eosinophils. So what you have to see is lots of eosinophils. So anytime you see eosinophils anywhere, you should at least be thinking of eGPA in your differential diagnosis, although the full spectrum of findings is very difficult to find in one biopsy. This is one of the rare cases where we were able to see necrotizing vasculitis in eGPA, and again, it destroys the vessel wall eccentrically, and you can see the innumerable number of eosinophils you see in that disease. Let's move to question 4. You see a necrotizing granuloma in a surgical lung biopsy. Although the appearance is suspicious for infection, special stains for microorganisms are negative. Which of the following is true? The negative special stains rule out infection. These findings are diagnostic of GPA. The best diagnosis is necrotizing sarcoid granulomatosis. Results of cultures will be important. Which of these is the best statement? Over to you, moderators.
Yes, sir.
I've got 8 minutes left, I think, so I'm going to have to go a little faster.
So
But
here
do we have
majority say it's option 4.
option 4? And they are absolutely correct. So results of cultures will be important because cultures can be positive even when the special stains are negative. And actually, the reverse is also true. Special stains can be positive and cultures can be negative. So special stains and cultures are complementary, and negative GMS and AFB stains do not rule out infection. You must remember that. So that's number 4 is indeed the correct answer. We showed many years ago in this study published in Chest that special stains were actually the most important thing, but cultures were also important, and there were many cases in necrotizing granulomas of the lung where special stains were negative, but cultures were subsequently found to be positive. Of the ones that were of unknown etiology, we looked at PCR and other things and found that if all the stains were negative and cultures were also negative, the outcome of these was very, very good in the long term, and there was not even a single incidence of disseminated disease or poor outcome. So resected necrotizing granulomas without organisms can be the residuum of a prior infection. The clinical course is benign on long-term follow-up. Just because the stains are negative does not mean that you have to make a non-infectious diagnosis like GPA. In fact, I would say the most common cause of a necrotizing granuloma with negative special stains is still infection, not GPA or necrotizing sarcoid. So with that, let's move to lung granulomas part 3, which is non-necrotizing granulomas. And we're going to talk quickly about this because we're running out of time. So let's start with question 5. Which of the following best supports a diagnosis of sarcoidosis in a patient with non-necrotizing granulomas in a transbronchial lung biopsy? Is it reticulin stain, surrounding lymphocytes, well-formed granulomas, or negative cultures and bilateral hyaluronopathy? I'll give you a few seconds to answer. Moderators, if you can help me with this.
So again, here majority say it's option 4, negative
4,
cultures.
and that is the correct answer. The correct answer is actually number 4, negative cultures and bilateral hilar adenopathy. So for a definitive diagnosis of sarcoidosis, the clinical setting is extremely important. It's very difficult to make a diagnosis of sarcoidosis by histology alone. You can pretty much only do that in a surgical lung biopsy, not in transbronch. You can suggest, you can say it's strongly suggestive or suspicious, but you cannot make a definitive diagnosis in the absence of clinical information. So number 4 is the right answer. Here's an example of sarcoidosis. So in a surgical lung biopsy like this, or a wedge biopsy, you do see the characteristic distribution along the interlobular septa, along the pleura, along bronchovascular bundles, and this distribution is virtually pathognomonic of sarcoidosis. But you do not see this distribution in smaller biopsies or in cytology. Here are the well-formed granulomas of sarcoidosis. They are always, or almost always, interstitial, are well-formed, are surrounded by concentric layers of hyalinized fibrosis, another very useful finding. And the lung away from the granulomas is normal. That's also helpful for sarcoidosis. Here's a high magnification image of a well-formed typical sarcoid granuloma. This diagnosis can be suggested in a transbronchial biopsy, or it's okay to leave it as just non-necrotizing granulomas, see comment, and then bring up sarcoidosis. Clinical setting is usually the patients are either symptomatic or asymptomatic, but cough and dyspnea can occur. There are many, many different symptoms depending on which organ is involved. Culture should be negative, and the imaging usually shows bilateral hilar mediastinal adenopathy, symmetric hilar mediastinal adenopathy, and bilateral symmetric lung nodules with a lymphangitic distribution. That imaging finding is very, very helpful. On imaging, the one good mimic is actually silicosis, but silicotic nodules are not truly granulomatous. They are formed of this lamellar kind of fibrosis in the middle, lots of dust, and that when you do birefringence, you can see silica and silicate particles in this. But radiologically, it can mimic the upper lobe predominance and hilar adenopathy that you see in sarcoidosis. Hot tub lung is not a great radiologic mimic, but is actually a very good histologic mimic of sarcoidosis because it forms well-formed granulomas. They can be profuse. They can look like they are in a lymphatic distribution, but they're not. They're actually within the air spaces. So in this granuloma you see here, it's okay, fairly well-formed, but it is within an airspace, not in the interstitium. And that is really key to the diagnosis of hot tub lung. Hot tub lung is a hypersensitivity reaction. But it's actually very rare in real life. And certainly you do need to ask the patient if they have a, if they work in a beryllium factory, obviously that would be important and can look similar to sarcoidosis, although it does not have the lymphangitic distribution. Very, very rare. Even for us, where we have a beryllium facility nearby, we virtually never see chronic berylliosis in our institution. Hypersensitivity pneumonitis is worth knowing about because this comes up a lot. Hypersensitivity pneumonitis is characterized by bilateral ground glass infiltrates, a 3-density sign, mosaic attenuation, and air trapping on imaging, and diffuse interstitial lymphocytosis with accentuation close to the bronchioles and ill-defined poorly formed granulomas and occasional multinucleated giant cells. It is related to exposure to organic antigens like birds most classically, or to sometimes to other things like mold in the home or feather pillows. Farmers also get hot tub lung. So farmer's lung hypersensitivity pneumonitis. So farmer's lung is a kind of hypersensitivity pneumonitis. If you see what's the difference between sarcoidosis and hypersensitivity? In sarcoidosis, you get well-formed granulomas. In hypersensitivity, you get an occasional scattered giant cell or a poorly formed granuloma. In sarcoid, lung away from the granuloma is normal. In hypersensitivity, lung away from the granuloma shows interstitial lymphocytosis, which is a very, very helpful feature. Here you see the characteristic giant cell with 2 cholesterol clefts in it. This is very common in hypersensitivity. Here you see the interstitial lymphocytosis. And that's all for hypersensitivity pneumonitis. Now, other thing where you can see granulomas is talc granulomatosis. This is where patients take their oral pills, like narcotic pills, and then they crush them up and inject them. So cause acute inflammation, organized pneumonia, a lot of acute pneumonia in patients who are not clinically thought to be aspirating, and it's particularly common in people who have had gastric bypass surgery. It's different than garden variety aspiration pneumonia that occurs in the right lower lobe and is caused by aspiration of colonized oropharyngeal bacteria. This is aspiration of food contents into the lung. Very different. And so the manifestations are very different, which are shown here. Basically, these are patients with gastric or esophageal disease. Infiltrates or nodules that can occur in any lobe. Swallow studies can be negative. They're found in lung biopsies, not in autopsies. They are found, instead of the food being in the lumen of the bronchus, can be found in the interstitium, and foreign body reactions and organizing pneumonia are common. Here I've shown you a whole range of cases that I've seen over the years where foreign body reactions to food were found in the lung parenchyma. And this is the wide range of morphologies you can see, from the classic septated vegetable material to more degenerated vegetable material, difficult to identify, to the so-called lentils that you see here and here. So the appearance of this can be quite varied, and the most degenerated particles actually are frequently misinterpreted or missed. And so the diagnosis of aspiration can be missed even by pathologists if you fail to recognize what aspirated food particles look like. The reaction is often of suppurative or foreign body granulomas with food or particulate material in a background of organizing pneumonia. Here you see the classic lentil type food material within these lesions. These lentils look very different from degenerated food particles, which you see on the right hand side, which can mimic the appearance of a blood vessel, for example. And finally, you can also aspirate sometimes tablets. Tablets that are taken for oral medication can sometimes be aspirated, and then you will see the same material that I showed you in the talc granulomatosis case. You will see cross-povidone and microcrystalline cellulose. The red arrows here show you microcrystalline cellulose, which is this gray material, very strongly birefringent. And then the yellow arrows show you cross-povidone, which is purple and not at all birefringent. And you frequently see them together when you when the material is a pill fragment, because they are frequently fillers within the same pill. So to summarize, the key feature that guides the differential diagnosis of lung granulomas is necrosis. Cultures are always important and can be positive even when stains are negative. And then some diagnoses like sarcoidosis, GPA, hypersensitivity are heavily dependent on clinical imaging and serologic findings, even though histology is helpful in these cases. So with that, I'd like to thank you for your attention. We're only 3 minutes over 40 minutes. And with that, I'd like to hand it over to Dr. Alpa and Dr. Mahima. Thank you so much.
Yes, ma'am.
Yeah, am I audible?
Yes, ma'am. You can
Yes,
continue.
ma'am.
Yeah, this is Dr. Mahima. A very concise and wonderful talk, Dr. Mukhopadhyay. And it's always a pleasure to listen to you. And it just reinforces everything which we do, especially the last line where you said that you need to correlate the radiology and clinical findings, and which is what we end up with many a times when the granuloma, an organism, is not seen in a necrotizing granuloma. It ultimately comes down to doing a clinical correlation with everything that we see. And I did like the point where you raised the point about NTM, that is non-tuberculous mycobacterium. We do see a lot of it. Unfortunately, not many people send cultures or send the appropriate material for testing. And it's the wonderful spectrum which you have shown of the necrotizing infectious granulomas, which forms the bulk of our clinical practice. And so the take home I would want the pathologist to take home is that when a sample is sent, when we ask samples to be sent to a biopsy or we do a biopsy, we always send a formalin sample and a saline sample. And I feel that the saline samples are not enough times sent for fungal cultures. They always send for tuberculous cultures in our country, but not always for fungal and NTM. And these are things that need to be added in the spectrum of investigation. It's always worth keeping a little bit of sample of this saline one, especially if you have a good coordination with your microbiology and the labs are close by, to say that keep some aside, because in case it doesn't come tuberculous positive, this is also some additional thing that we want to run. I understand that costs can be there in running the cultures, uh, all the cultures in all the time, but it is worth doing that, to have an additional sample doing that, because we have often got positive culture yields after everything being negative over here in the NTM or the fungal cultures.
Great points. Those are great points. Actually, I find that that's a problem sometimes even here, that especially when an interventional radiologist is biopsying something with a CT guided needle biopsy, and they're thinking, the main thing they're trying to exclude is malignancy. Often they will stop just at biopsy and no cultures, because they're thinking, I want to save tissue and make sure we have enough for molecular. And I understand that. I understand that malignancy is the main thing, and cultures are difficult. But there is a very interesting saying that one of our orthopedic surgeons used to say. I think that's a really good saying. He used to say, biopsy all infections and culture all malignancies. What he was trying to say is that broaden your differential diagnosis. So don't assume that every time you think something is malignant, it will turn out to be malignant. And don't assume everything you think is infectious will turn out to be infectious. And just keep an open mind and, send for the other modality too.
Absolutely. And I think we have a lot of crosstalk with our pathologist always, that, hey, this is what I think radiology is looking like, and I want you to run this. And the typical, in practice, what I see of a necrotizing granuloma, they'll be always tested for AFB, but GMS and past stains, more often than not, we have to call in and say, I want these stains added in. So I think that should be a protocol, that when you see these are 3 stains, which as a clinician for me is something that should be done on the pathology sample. Whereas
Right.
most places,
can I ask you a question, Dr. Mahima?
Yeah.
Can I ask you, when you do get fungal infections in India, what do you see the most in granulomatous disease? Do you see the infections that I talked about here?
So I see histoplasmosis probably the most, but then I'm working a lot in Tata. So we do get histoplasmosis mimicking tumors, and we pick them up or on their chemo. So histoplasmosis would be there. The other set that I see is cryptococcus.
Yes.
And so I have my immunocompromised host patients in those spectrum, which is even HIV or even diabetics, I would get cryptococcus. But these two would be my 2 primary ones. I have yet to see a coccidiomycosis. I think in India, they're all imported cases. We've not had any indigenous ones. And even blastomycosis is, I think, very few far in between. In fact, I think US has just had some place in Michigan has just had a entire paper mill or pulp mill workers have come out with blastomycosis just yesterday or something. Yes. And so we don't see much of these, but cryptococcus, yes. And I think they used to, I still remember a discussion once in one of my patients where there was a discussion between cryptococcus and Candida glabrata, and to differentiate these two on histopathology, because the cultures had not been sent, it was just a biopsy, and it then turned out to be cryptococcus itself. But these two would be my front runners amongst the spectrum that you did show. We do see aspergillus and all of them, but they don't come with this pattern. I also see bronchocentric granulomatosis in my asthmatics and ABPA patients. So that is one thing, that we do see.
Yes. I think that's one thing I didn't mention. ABPA is, I should have put that in as well. that you
Yeah.
can get granulomatous disease there. Yeah, that's a very
Yeah,
good
so
point.
if it's my IBPA patient and I get a necrotic lesion, I may still see fungus, but for me, that's bronchocentric granulomatosis.
Yes. Yeah.
And the way for me as a clinician is generally more bronchial centric disease versus my GPAs and my EGPAs, which are more peripheral and vascular based and more distal based necrobitic nodules. Those are all distal based diseases on radiology clinically
Right.
as well.
Right.
Yeah.
Great points. Yeah. Great points. Any other questions? Anybody?
We would
So
like
we
to have Dr. Alpa ma'am's opinion as
Yeah.
well. Yours. So, Alpa ma'am?
You're muted.
Hi, can you hear me?
Yes,
Yes.
ma'am.
Okay. So
Yes,
Dr. that was very excellent, comprehensive presentation. And even as a clinician, I really enjoyed, I almost felt like I have very good points to discuss when I next go and question my pathologist about the diagnosis. So apart from whatever points Mahima has said, that I fully agree that, asking for the right sample, asking for cultures, that's very important. And I think we need to create this awareness amongst especially our surgical colleagues, so because many times we as pulmonologists get the patient referred who are halfway through their workup, so already biopsy has been done and histopathology has been given. And by the time the patient comes to us, we have lost the opportunity to ask again for the culture. So that is very important. And having a communication between the clinicians, pathologists, and radiologists, I think that's extremely important. And though we know that it should happen, but it really in our busy practices, practically doing that, meeting up with the pathologists and that doesn't happen as often as I would like to. But, very often I still go to my pathologist and just sit with her and try to understand the slides and then try to understand why she's making, particular diagnosis. And that really helps us to understand each other's perspective. See, from a clinician's point, I would like all the pathology students also to know that, so pathology comes much late in the picture. So once we see the patient, we just find out what the diagnosis could be, what could be multiple comorbidities of the patient, how patient is going to actually, how risky it is for the patient to undergo the invasive test and affordability, because here in India, patients all pay for themselves. And the third question I asked myself that how the pathological diagnosis is going to add to my management or going to change the management. After having done that, I would actually sit and plan as to what all different biopsies we need to take. For example, if I have suspicions of sarcoidosis, then in a given setting, I should plan that, I should do bronchoscopy, we take a transbronchial biopsy, endobronchial biopsy, and also in the same setting, if there are mediastinal nodes, I should do EBUS and get that sample too. So this kind of planning is extremely important from clinician's point of view. And one more thing I would like to point out that there are many situations where coexistence of different granulomatous diseases does happen. So in India, particularly, coexistence of sarcoidosis and tuberculosis is pretty common. And that's the reason where important point that you made in non-infectious granulomatous is we have to actually wait for the culture. And I really like that point because, one particular case I had, she was referred to me by a cardiologist because she presented with typical features of cardiac sarcoidosis. And the PET scan was done and she did have the nodes and we biopsied the node. It was a peripheral node. And then pathologist was too confident that this is a non-necrotizing granuloma and she's likely to have sarcoidosis. But I'm extremely skeptical in India waiting for the culture report to start this patient only on steroids. It can be disastrous. So she also was uncontrolled diabetes. So not listening to my pathologist colleague actually started this patient on steroids along with anti-tuberculous medicine drug. And after 4 weeks, the culture comes positive, and that showed that this was a resistant tuberculosis. Okay. So these kind of things happen. So coexistence, and she did have features of sarcoidosis. And actually, when I had this resistant tuberculosis report coming in, I repeated the PET scan, and though her mediastinal lymph nodes had responded on the first line AKT. So there was coexistence of the disease, and these are common scenarios. When hypersensitivity pneumonitis is also very common in our country, many times they come with a burnt up disease, or many times the radiological features are very typical. We may not end up doing biopsy. So here, one more thing I would like to point out, and I would also want your feedback, that as clinicians, sometimes we face situations where we would love to have the biopsy, but patient's condition is not good enough to withstand this invasive procedure. And then we rely on some less invasive procedure like doing bronchoalveolar lavage. And how this bronchoalveolar lavage, different type of analysis or doing CD4, CD8 counts can actually help clinicians in reaching the diagnosis where more invasive procedures are not possible. So these kind of scenarios also happen. I would love to have your inputs on this.
Yeah, these are great points. All really good points. I would like to address the question about the bronchoalveolar lavage. So if you have a localized lesion, the OMA things, the localized necrotizing granulomas, at least in my experience, the yield of bronchoalveolar lavage in those settings is very low because, the infection is sort of walled off. But if you have disseminated infection, I think those situations, BL is very, very helpful. I've seen several situations where, not only pneumocystis, but you can have cryptococcus, you can have disseminated histoplasmosis, actually more easily visible in a BL specimen than it would be in a biopsy. So I think that you can really make the diagnosis in the most important settings, which is the ones with disseminated disease. I think their BL is really good, and I find that the people who do, the pulmonologists, interventional pulmonologists who do EBUS and who do bronchoscopic procedures are very good about sending cultures. Usually, at least in our institution, they are very cognizant of the fact that multiple samples need to be sent to different places, and so the yield of those for cultures is very high in the disseminated setting.
Okay, so that's good. So these are the points I wanted to make. One of the common existence we find is non-tuberculous mycobacteria and tuberculosis existing together. That's also a pretty common scenario. Patients having extensive lung disease and having a cavitary disease. So we many times see cultures growing both Mycobacterium tuberculosis as well as non-tuberculous mycobacteria. That's also a common scenario we see in India. And malignancy and TB is also we see commonly, but of course, they are not really talking about the granulomatous here, but these two conditions we see commonly coexisting.
Yes, not surprising, right? Given how common TB is, it's not surprising that by chance you will have it happen with other things. It would be a nightmare to like for a pathologist to tell that apart. In fact, it would be impossible for a pathologist to tell whether this is TB alone or NTM alone or TB and NTM both together. I mean, that really is a microbiology plus clinical diagnosis, right? Yeah.
And I think after getting the inputs from the pathologist, many times we do revisit the case, go back into the history, find out things, and we should be willing as clinicians, we should be willing to change or reconsider our diagnosis. And that's very important. I think having a good communication between pathologist and clinician, that's the most important thing. And I think as clinicians should play a key role in coordinating between the radiologist and the pathologist and their own teams.
Yes. I do find that the more the clinician is or the pathologist, both of them, the more they're willing to just pick up the phone and talk to the other person, the better it is for everybody.
Absolutely.
So with that, we will really like to thank you for that very lucid talk. We have a few questions, sir. If you can just stop sharing your presentation,
Oh, of
then we
course, yeah.
can. Yes, sir.
Here we go. Sorry about that. Yeah.
Komal, you can go ahead with the question.
So we have one question from Soumya. How to differentiate organizing phase of pneumonia from DIP?
You've asked a good question, but okay, let me just put it like this. So first of all, organizing pneumonia is basically made of fibroblasts, right? Those are plugs of fibroblasts that fill the alveoli. So you see, branching and snaking fibroblast collections that follow the contours of the air spaces. They're frequently clustered around the airways, and actually that's a very good correlation to the imaging where you typically see ground glass opacities or consolidation that is surrounding an airway. You get a sort of air bronchogram in the middle and so forth. So organizing pneumonia is all fibroblastic. DIP is actually a very, very bad term for macrophages filling the air spaces. There's nothing desquamated in DIP. So I've never used the term DIP. I hate it. I've written papers about how we should get rid of it, but this is just embedded in people, in the people's, it's like caseating necrosis, you will never get rid of that term because people just, but what DIP is macrophages filling the air spaces. And in the majority of cases, it's macrophages due to smoking. So histologically, it looks nothing like organizing pneumonia. There should be no confusion. One is fibroblast, the other is macrophages.
Okay,
Any other?
ma'am, I have a question for Alpa ma'am and Mahima ma'am. This is regarding the bowel fluid. So there is when we do the procedure, even when we do the differential count. So as far as the differential count is concerned, the papers say that if it is more than 5% columnar epithelial cells is generally not representative, the inflammatory pattern. So, like many a times I find in our setup, we get these samples where we find a lot of these columnar epithelial cells. So what exactly is the technical issue there? And do we, what kind of feedback we can give to our clinicians, and, how do they tackle this?
Shall I take that, Alpa? Yeah. Okay. So when we do BAL, actually you wedge into a segment. And the first, we put alicos. So we put alicos of 20 ml each time. So the first alico which you put in, you are not supposed to take for a BAL cellular analysis, because that is going to give you a airway cells. What you want to do is an alveolar lavage. So the
Right.
first alico we actually remove and take, and we put it for infection. Okay, because anything
Okay.
which has come forward would be there. And from the second alico onwards is where, and you don't come out of that segment. From the second alico one is the one you start taking for a bowel lavage. So more often, either the person is changing multiple segments, because a bowel proper means a wedged in. Anything else is a bronchial washings. So bowel is where we sit in a segment, identify it on the CT, and we put about 100 to 150 ml of saline in. But the first alico should never be contributed in, should be taken out. We take it out actually for all our PCR based testing, because pneumocystis and all we can get better in our cellular, they're intracellular. So we'll see them better in the complete cellular analysis when we do. And we remove this first sample for all infections. So you probably have either someone not wedging or going to multiple lobes and collecting more airway cells, or not following this thing of removing the first alico.
Okay. And ma'am, anticoagulant of how do you transport your samples, the bowel fluid samples,
So,
or what is the
yeah,
preferred?
so the bile fluid has to be analyzed very fast. So it has to go immediately from your lab to the pathologist, and it has to go through the cytospin. The cell pellet has to be collected, and then that is used for analysis. If you're going to make it sit, you're going to lose your material which you have. So when we do BAL, we call the cytologist before and tell them we're starting a BAL. And that's why even our BALs, we are not allowed to do anything beyond 3 o'clock, because that means the person is going to
hours.
sit beyond
Yes, yes.
5.
Yes.
Yes. So you have to do it. And a common mistake which is done by many is they analyze the BAL like ascitic and pleural fluid, and that's not the way it's to be done. It has to go through a centrifuge, separate the supernatant and this, and then take only the cell pellet which has to be analyzed. And you can use your regular cytospin which you have. You just need that. I think you need about 3,500 RPM one, which is needed for doing that.
Okay. Okay.
Yeah.
Fine. I think that is all for the day. So any final comments from Dr. Sanjay sir
I have,
or yeah,
ma'am, I
yeah.
have a
Go ahead.
question for both of you, being the clinicians. How is the treatment different between histoplasmosis, cryptococcosis, and blastomycosis?
So blastomycosis I've not treated, so I've really not seen any. So I'm not good. But they are generally antifungal. So if there's a histoplasmosis, you have to also look for disseminated form. Okay. So in histoplasmosis, you have to look for CNS involvement, especially in your patient before you initiate any therapy. So if you have any CNS involvement, we do an MRI, we do an LP also, look at the CSF and make sure there's none. Because if there's any CNS involvement, then the treatment of choice is amphotericin. Then you're not going to start with anything lower than that. But if you have a very localized pulmonary or like this, most of the cases which we see, they come from the Ganges belt. They will generally have a mediastinal node as well as adrenals. And they are very classical cystic type of adrenals which are there. And so we sometimes see Addison's disease also along with it. So you have to look for that. And those are manageable by itraconazole as well. So then the treatment really doesn't matter. For cryptococcus, again, the same thing. You know, you are going to look for cryptococcal meningitis or not, because more often than not, it's an immunocompromised host. So that's going to take your call of localized versus disseminated and plus or minus CNS involvement. And Alpha, you have been,
Yeah, thank you, ma'am.
Yeah, I agree. Non-disseminated ones we treat with itraconazole. Big issue happens that it's such exact mimic like tuberculosis, and very often when you don't grow the culture, most of people end up getting an empiric anti-TB treatment. You know? They don't respond, then further investigations or just reconsideration with empiric itraconazole happens. So majority of them, they get treated with anti-TB empirically.
Yeah, I think because cryptococcus comes up more for HIV patients for us. And generally, those are the patients who have like a lower CD4, and the CD4 itself dictates that they go on to antifungal prophylaxis. So below a certain point, they're generally on that. So your threshold for initiating an antifungal in the therapeutic dose is probably, your trigger point is probably much earlier than not. It's only when it comes as an innocuous diagnosis suddenly in an immunocompetent or not that immunocompromised host that you are faced with these questions for us in practice. Yeah.
Again, another question, ma'am, very basic. When do you exactly say clinically that the patient is not responding to antituberculous treatment? Like, how long do we wait? Or, when you go back and relook at the case?
Yeah. So basically, this again depends on the immunocompetent status of a patient or the general status of the patient or the kind of disease. Suppose a patient is immunocompromised and patient has got disseminated disease, and patient is quite sick in the ICU. Then we wouldn't wait for long before deciding that this patient is not doing well. So you will be very aggressive in repeating the cultures, repeating the samples, or sometimes rebiopsying the thing. But if a patient is stable, then generally it is only up to 8 weeks we decide that if patient is not responding, and we see on 3 counts. One is clinical improvement, second we look at radiological improvement, and third we look at microbiological improvement. So on all these 3 fronts, patient has to respond. If they don't, then we think that patient is not responding. And then if we don't have a culture diagnosis to begin with, then we would think of re-investigating or rebiopsying the patient. And or if the culture diagnosis was there, then we consider the patient may be having drug resistant.
Okay. So I think that was quite clear thank you, sir. Thank you, ma'am, for an excellent discussion. I think we all really enjoyed the session. So any final comments from any of you before we just call it a day?
Thank you all for coming, and thank you for the lovely discussion. Thank you.
Thank you.
So I'll just take 2 minutes. I have just